So Dr. Enas Farouk is an anesthesia consultant originally from Alexandria, Egypt. She practiced anesthesia in the Arab Emirate for 10 years in Dubai, in the Northern Emirate in Abu Dhabi as well, where she gained respect and fame among her colleagues and patients. She used to give talks as an active member of Abu Dhabi Anesthesia Club. Then she moved to Ottawa, the federal capital of Canada, where she earned 2 degrees from the University of Ottawa, both the Faculty of Medicine and the Faculty of Education. She is now working to earn a degree in holistic nutrition. Dr. Enas was also trained in CADTH, which is Canadian Agency for Drug and Technologies in Health, and she has great experience in the field of medical research, evidence-based medicine, and study formulation. She is also a staff member in the Faculty of Medicine, Alexandria University, and today she is going to talk to us about one of the most important safety issues regarding the regional and pain medicine, which is local anesthetic toxicity. Thank you, Dr. Enas, to be with us today.
Thank you very much, everyone, for having me. I first of all thank Dr. Saad for adding me to this elite group of presenters. I will start now sharing my screen.
Yeah, please.
So, about toxicity of local anesthesia. I was fortunate enough to study in 4 of the elite educational institutions in the world: the Faculty of Medicine, Alexandria University, the University of Ottawa, the Canadian Nutrition, and the Canadian Agency for Drugs and Technology in Health. The learning objectives for today are: learn a little bit about the history of local anesthetics, define local, identify the toxicity from local anesthesia can happen.
Hello, Dr. Enas, are you still with us? Hello?
Just to give her a second, she's reconnecting most probably. I don't know what's going wrong.
Recognize the forms of toxicity. Can I continue?
Yeah.
You missed the first slide, I think.
Hello?
From the first, please. Dr. Enas, come back from the first slide, please.
Can I continue?
We lost you for a few minutes. I think we missed the first slide.
Can I continue, everyone?
Yeah. Would you please start from the beginning again, Dr. Enas, if you don't mind? Dr. Enas, do you hear me?
Sorry for that. You know, you have seen the preparation even before we starting. Dr. Enas.
دكتور سعد أنا أونلاين والصوت مش طالع عندكم.
I know. No, we hear you very well. We hear you well. We hear you well. We hear you well. Dr. Enas, you can speak from the first slide, from the beginning, please.
أكمل, I'll continue? Okay, تمام. So I'll go through the learning objectives again. And then we start with the history. So in the 13th century, the Incas regarded coca as the gift from the sun god. Here they are dancing and celebrating the sun god. Coca leaves were chewed and applied as local anesthesia before trepanation for persistent headaches. Here we can see a witch doctor performing trepanation. This is a skull of an Inca with trepanation in it. That's an ancient machine, a new module of doing trepanation. Medical use of local anesthesia began after the isolation of cocaine from coca in Peru at 1860s. This is the flower of the coca. This is Mr. Cooler. He used cocaine as a topical anesthesia for conjunctiva, and that's the cocaine powder. Then the medical use of cocaine spread. American surgeon Halsted used cocaine for the mandibular nerve and brachial plexus block in the 1885. Spinal anesthesia by Monsieur Bier, this started in the 1898. And then the caudal block was developed by Monsieur Sekar and Kathleen in 1902. What are local anesthetics? Local anesthetics is a drug that causes reversible local anesthesia, generally for the aim of having local analgesic effect. That is inducing local insensitivity to pain sensation, although other local senses are often affected as well. So when it is used on specific nerve pathways like the nerve block, paralysis, which is loss of muscle power, can be achieved as well. The aim is no pain. Clinical local anesthetics belong to one of two classes, the amino acids, the aminoamides. This is their chemical composition. So we have three parts of each local anesthetic. The aromatic ring determines the actual degree of lipid solubility. The intermediate linkage determines the pattern of biotransformation, that is metabolism. And the terminal amine acts as an on and off switch. Local anesthetics in clinical use made easy. So the names of each locally clinical anesthetic have the suffix "-ane in it. In general, amides have two I's in their name, while the esters only have one, and this is important, remember it. Esters are prone to producing allergic reactions, which necessitate the use of an amide. Most ester local anesthetics are metabolized by pseudocholinesterases. Amide local anesthetics are metabolized in the liver. This can be a factor in choosing an agent in patients with liver failure. So don't forget, amides has two I's and esters has one I. So here is some example of amides: lidocaine, lignocaine, bupivacaine, ropivacaine. They are all metabolized by the liver. Some esters are benzocaine, procaine, cocaine. They are metabolized by pseudocholinesterases. So the combination is local anesthetic mixed with other local anesthetics, including lidocaine, is the EMLA cream. It's called eutectic mixture of local anesthetics, and we have all used it for applying cannulas in young children and people who can't stand the pain prick of the cannula. So the mechanism of action of local anesthetics, all local anesthetics are membrane stabilizing drugs. They irreversibly decrease the rate of depolarization and repolarization of excitable membranes like nociceptors. So the voltage-gated sodium ion channels that Dr. Kafafi spoke about, local anesthesia act mainly by inhibiting sodium influx through sodium-specific ion channels in the neuronal cell membrane, in particular the so-called voltage-gated sodium channels. But local anesthetics bind and inhibit many differing receptors and channels. Sodium channels through the enzyme adenyl cyclase and the nicotinic receptors, calcium channels through guanylyl cyclase and acetylcholine receptors, potassium channels through the enzyme lipase and beta-2 adrenergic receptors. So don't assume that local anesthesia toxic effect arise from sodium channel inhibition alone. SALA or LALA. The binding of short-acting local anesthetics SALA to the sodium channel is often characterized as fast in, fast out. But the binding of long-acting local anesthetics LALA to the sodium channel is often characterized as fast in, slow out. The potential for serious toxicity of long-acting local anesthetics is higher compared with short-acting local anesthetics. The main negative cardiac effect of long-acting local anesthetics is adverse influence on cardiac electrophysiology. It aims for the electricity of the heart. Border toxicity was found to be racemic bupivacaine more than levobupivacaine and more than ropivacaine. Thus, ropivacaine appears to be the least toxic of long-acting local anesthetics, therefore should be used routinely in children with the exception of spinal anesthesia. Why are local anesthesia used? Because as humans, we have pain. We get headaches, we have back pains, we have bone pains, joint pains, muscle pains, and all your patients will tell you, no pain, please. Local anesthesia in a strict sense is anesthesia of a small part of the body, such as a tooth or an area of skin. Regional anesthesia is aimed at anesthetizing large parts, such as a leg or an arm. Conduction anesthesia is a comprehensive term which encompasses a great variety of local and regional anesthetic techniques. And of course, anesthesia means less staff and the patient feels more involved. Local anesthetics vary in their pharmacological properties, and they are used in various techniques of local anesthesia, such as topical anesthesia, surface anesthesia, infiltration, like for the head, or ring finger block, or now widely used as hair transplantation. Plexus blocks, either conventional or ultrasound guided. Epidural or spinal anesthesia, and of course, we as anesthetists all know the difference anatomically between the arachnoid space, subarachnoid space, and the epidural space. Adverse effects depend on the local anesthetic agent, method, site of administration, but overall adverse effects can be localized prolonged anesthesia or paresthesia due to infection, hematoma, excessive fluid pressure in a confined cavity, and severing of nerves and support tissue during injection. It can be also systemic reactions such as depressed CNS syndrome, allergic reaction, vasovagal episode, and cyanosis toxicity. The third thing, it can be lack of anesthetic effect due to infectious process in situ, such as an abscess. If you inject local anesthesia in an abscess, it won't work. Local anesthetics have provided an alternative to general anesthesia ever since their first clinical use more than 120 years ago. While generally safe, local anesthetic agents can be toxic if used in excessive doses, administered improperly. Even when administered properly, patients may still experience unintended reactions to local anesthetics. Excessive doses may be unintentionally administered in several ways, like repetitive small doses of local anesthetics to achieve an adequate level of anesthesia may lead to eventual toxic dose. Injection of anesthesia in a confined space may result in excessive fluid pressure that may damage nerves. Doses intended for epidural or intra-support tissue administration may be accidentally delivered as intravascular injections, resulting in accelerated systemic absorption. How about pediatric patients? During the research of interest in pediatric regional anesthesia during the second half of the 1980s, no clear knowledge existed with regard to safe dosing of racemic bupivacaine. The American Patient Safety Foundation sponsored a study that was able to define safe dosage guidelines for the use of racemic bupivacaine in newborn and older children. As the vast majority of patients are asleep when the block is placed, early symptoms are not possible to detect. Thus, the first signs of toxicity in these settings are seizures, tachyarrhythmias, or cardiovascular collapse. The use of a test dose of local anesthesia with added epinephrine is advocated by some authorities for the early identification of an inadvertent intravascular injection of local anesthesia. It is important to realize that the test dose will not provide early warning signs of rapid absorption of local anesthesia from the injection site. The most informative clinical sign of intravascular injection is dependent on the anesthetic technique. So the incidence, epidural anesthesia 1.2 to 11 in 10,000 in labor epidural. It was 100 in 10,000 before the 1980s. Peripheral nerve blocks is 2.5 in 10,000. Dentists perform thousands of local anesthesia injections daily with minimal adverse effects. Toxicity can be localized. A cause of local toxicity is allergic reaction to para-aminobenzoic acid, PABA. These reactions range from urticaria to anaphylaxis. Para-aminobenzoic acid is a metabolic product of the degradation of ester class of local anesthetics, such as Procaine, Novocaine, which is used by dentists, and to a lesser degree, amide class anesthetics, such as lidocaine. It's also a metabolic byproduct of pra-mod-methylpropane. It's a preservative in a multi-dose vial of lidocaine. Local forms of toxicity can be myotoxicity. When injected into muscle, local anesthesia may produce tissue necrosis at the site of administration. Neurotoxicity. At high local concentrations, all local anesthetics are neurotoxic in laboratory models. Clinical local anesthesia solutions nearly always include additives to adjust pH and growth, which makes it difficult to assign blame for toxic side effects solely to the local anesthesia molecule. It can be the preservative, it can be the additive. Local anesthesia systemic toxicity or LAST. Systemic toxicity of local anesthetics can be described by the direct effects on the immune system, blood, central nervous system, and cardiovascular system. Local anesthetic systemic toxicity can be directly related to the plasma level of the free drug, which is directly related to the total dose. Accidental intravascular injection can happen, absorption from tissue depot, metabolism, elimination, repeated doses without elimination. The risk factors include block area. Neck or epidural in pregnancy has high vascularity. The local anesthetic agents, bupivacaine is cardiotoxic. Physiological condition, a newborn or old age or pregnancy. Liver functions and blood flow clearance of amide local anesthetics. Renal impairment, ischemic heart disease like conduction defects. Drugs, beta blockers, calcium channel blockers, and digoxin. Human error, a wrong dose can be given, which is very rare. And luck, bad luck happens sometimes. Maximum recommended dose. The maximum dose is not an evidence-based and has poor approximation of safety in animal data. For adults, neither the body weight nor the body mass index correlate with peak plasma levels of local anesthesia. The ASRA, which is the American Society of Regional Anesthesia, has a definition of the safe dose. It should be block specific and related to patient's age, organ dysfunction, and whether the patient is pregnant. The ASRA, the American Society of Regional Anesthesia, has guidelines on local anesthesia systemic toxicity. It compromises that using the lowest clinically effective dose reductions for patients who are at high risk for local anesthesia systemic toxicity, like less than 6 months old, than 70 years old, with conduction defects or ischemic heart disease, and patients with low ejection fraction. Prevention of local anesthesia systemic toxicity. Use of minimal effective dose. Careful aspiration, but it can give you 2% false negative. Incremental injections with the risk of needle migration. Use less toxic local anesthesia, the L-enantiomers like L-bupivacaine and ropivacaine. Also on the prevention of last, use of ultrasound, which is widely used now by many anesthesiologists and anesthetists all over the world. Use of intravascular markers when large doses are used. Epinephrine 10 to 15 mic per ml and adults 0.5 to mic per kilogram in pediatrics. Epinephrine might be in place of beta blockers, advanced age, general combined with epidural and active labor. Surgeon's awareness is very important in prevention of local anesthesia because some of us can give local anesthesia and leave the patient for the surgeon after a while. And if the surgeon is not aware that something wrong can happen, something wrong can really happen. The ASRA practice guidelines on last. The pharmacological treatment of local anesthetic systemic toxicity is different from other cardiac arrest scenarios, and please pay attention to this. Reduce individual epinephrine boluses to less than 1 mic per kilogram. Avoid vasopressin, calcium channel blockers, beta blockers, or other local anesthetics. This is what I'm going with you later. Guidelines for the management of severe local toxicity. The CNS.
Dr. Enas, we missed some slides from you. Dr. Enas? Dr. Enas, do you hear me? We missed a few slides from you.
The CNS manifestations are biphasic, excitatory, tongue numbness, headedness, tinnitus, metallic taste, restlessness, and convulsions, followed by depression, confusion, obtundation, unconsciousness, respiratory arrest and cardiac manifestations. Local anesthetic toxicity may occur sometime after the initial injection, so always pay attention to your patient even after 30 minutes. Cardiac manifestations due to blockage of cardiac voltage gated sodium channels, potassium channels, and calcium channels usually follow CNS effects, except with
Dr. Enas? Hello, Dr. Enas. We missed some slides from you.
Ventricular dysrhythmias and conduction defects common with bupivacaine. Ventricular arrhythmias may all occur, so please pay attention to that. ECG changes can happen. Conduction block sinus bradycardia, followed by asystole resistant to resuscitation, cardiovascular collapse. Pregnancy, hypoxemia, and acidosis increase incidence of cardiovascular toxicity. How about pediatric patients?
My apology for that technical.
So early signs of local anesthesia toxicity, alteration of mental status and muscular twitching may be possible to detect if the child is awake, given techniques as used awake codal blockade in premature babies. In the postoperative period, if continuous infusion techniques are used. However, these signs are easily missed, misinterpreted, and maybe even taken as signs of inadequate pain relief.
Dr. Enas,
so when faced with a clinical situation of unclear postoperative problems in a child with an ongoing infusion of local anesthesia, one should always consider whether the symptoms may reflect early signs of local anesthesia systemic toxicity or not. AGABI, which is the Association of Anesthetists of Great Britain and Ireland, and ASRA, which is the American Society of Regional Anesthesia, have guidelines. So management of suspected cases, stop injecting the local anesthesia and call for help. Call for help. Maintain the airway and if necessary, secure it with a tracheal tube. Give 100% oxygen to ensure adequate lung ventilation. Hyperventilation may help by increasing pH in the presence of metabolic acidosis. Hypoxia and acidosis exacerbate toxicity and hinder resuscitation. So mind the airway. Confirm or establish intravenous access. Control seizures, give the benzodiazepine. Benzodiazepines are the key. I don't hear you. من امتى? I will start again or what?
When I tried prevention of last, I use ultrasound intravascular marker.
Okay. Can you hear me now? I keep getting muted by the host. I keep getting muted by the host, by the way.
No.
I'll start again.
Okay. Yes,
you can hear me? Where do you want me to start from? From here?
No, I don't hear you.
Okay, I will start again from here. So when faced with the claim, muted by the host.
No.
I am muted by the host. When faced with a clinical situation of unclear post-operative problems in a child with an ongoing infusion of local anesthesia, one should always consider whether the symptoms may reflect early signs of local anesthesia systemic toxicity or not.
Voice is gone.
The Association of Anesthetists of Great Britain and Ireland and the American Society of Regional Anesthesia both have guidelines. So immediate management, stop injecting the local anesthesia, and call for help. Call for help, people. Help is needed.
I'm really very
Maintain
sorry
the airway and if
call.
necessary, secure it with a tracheal tube. Give oxygen and ensure adequate lung ventilation. Hyperventilation may help by increasing the pH in the presence of metabolic acidosis. Hypoxia and acidosis exacerbate toxicity and hinder resuscitation. So make sure the airway is maintained. Confirm or establish intravenous access. Control seizures and give benzodiazepines. They are the key. Remember that benzodiazepines are the key. Or thiopental or propofol if benzodiazepines is not immediately available. Avoid propofol if myocardial instability is there and give in small incremental doses. Remember the key is benzodiazepines. Management of cardiac arrest associated with local anesthesia injection. Remember, if the patient is pulseless, start CPR using standard protocols. Manage arrhythmias using the same protocols. It may be very refractory to treatment. The patient may need prolonged resuscitation and may be necessary. Consider the use of cardiopulmonary bypass if available. CBP, cardiopulmonary bypass. So we use lipid emulsion 20%. First, if the patient is greater than 70 kilograms, you give a bolus of 100 ml of lipid emulsion 20% rapidly over 2 to 3 minutes. The lipid emulsion infusion then continues 200 ml over 50 minutes, over 15 to 20 minutes. If the patient is less than 70 kilograms, you give a bolus of 1.5 ml per kilogram lipid emulsion 20% rapidly over 2 to 3 minutes. And then continue the lipid emulsion infusion 0.25 ml per kilogram per minute of ideal body weight. If the patient remains unstable, rebolus once or twice at the same dose and double infusion rate. Be aware of dosing limits 12 ml per kilogram. The total volume of lipid emulsion can approach 1 liter in a prolonged resuscitation more than 30 minutes, and which is usually refractory to that. Start lipid emulsion. Continue infusion until rate to 0.5 ml per kilogram per minute if blood pressure declines. Continue infusion for 10 minutes after attaining circulatory stability. So once your patient is stable, you have to continue for another 10 minutes. Continue monitoring for at least 4 to 6 hours after cardiovascular event or at least 2 hours after a limited central nervous system event. As local anesthesia are lipophilic drugs, the free and bound local anesthesia in circulation will be taken up by the lipid part of the plasma and thereby being sequestered from having its effects. Formation of a lipid sink that absorbs the circulating lipid-soluble toxins, reducing the free toxins available to bind to the myocardium. They are taken up in a lipid sink and then flushed out of the body. Proposed mechanism of lipid action. After infusion, the lipid emulsion exists in blood as emulsified droplets or multilamellar vesicles. They are captured the local anesthetic, which is the lipid zinc formulation. Increased fatty acid uptake by mitochondria, metabolic effect. Interference with local anesthetic binding of sodium channels, membrane effect. Activation of AKT cascade leading to inhibition of GSK3. Cytoprotection effect has been implicated in preventing myocardial ischemia in reperfusion injury. Promotion of calcium entry via voltage-dependent calcium channels, ionotropic effect. Accelerated shunting pharmacokinetic effects. Remember, continue CPR throughout treatment with rapid emulsion. Continue chest compressions. The lipid must circulate. Recovery from local anesthesia induced cardiac arrest may take more than 1 hour. Don't give up after 40 or 45 minutes. Propofol is not suitable substitute for intralipid. Replace your supply of intralipid 20% after use. Lidocaine shouldn't be used as an antiarrhythmic therapy. Remember, benzodiazepines are the key. Without circulatory arrest, use conventional therapies to treat hypotension, bradycardia, and tachyarrhythmias. Follow-up action. Transfer to a clinical area with appropriate equipment and suitable staff until sustained recovery is achieved. Exclude pancreatitis by regular clinical review, including dairy amylase or lipase assay for 2 days. If lipid was used, please report it, the use at lipidregistry.org. If possible, take blood samples into a plain tube and heparinized tube before and after lipid emulsion administration, and at 1 hour intervals afterwards, measure the local anesthesia and triglyceride levels. Your nearest bag of intralipid is kept in. Always remember, if you are using local anesthesia, you should have lipid there. Local anesthesia toxicity kit plus instructions, and always be BSV. Be sensible. Use the least dose to attain the desired duration and extent of the block. Aspirate and inject incrementally. ID patients who are susceptible for local anesthesia systemic toxicity, either too small, too big, too old, too fat, pregnant. Use a pharmacological marker or a test dose. Be vigilant. Use standard ASA monitors. Monitor during, monitor after for at least 30 minutes and communicate frequently with your patient. Light sedation might abolish toxicity symptoms. Consider local anesthesia systemic toxicity in any patient with altered mental status, neurological or cardiovascular symptoms, even if only small doses have been injected. Give big attention to small susceptible patient, atypically administered like subcutaneous or mucosal or topical anesthesia, administered by surgeon, and after recent tourniquet deflation. Thank you very much from Ottawa, and that's my email if anyone wants to connect with me.
Thank you very much, Dr. Enas. We just have some question here, and first one is like about the regional anesthesia in anesthetized patient. Do you think the performance of local anesthesia, even if under ultrasound guidance in a sleep patient?
I'm sorry, I can't hear you. You're unmuted.
Hello? Can you hear me now? Hello, Dr. Enas? Hello? So, okay, so Dr. Enas can't hear us well, and so I will do something. So, Dr. Enas, I'm recording my question to you now. If you can answer it, it's about the incidence of local anesthetic toxicity if you will perform your regional technique or regional block even under ultrasound guidance in a patient who is under general anesthetic. Do you believe it increases the risk of toxicity or not? Can you hear me now?
Recording my question to you now. If you can answer it, it's about the incidence of local anesthetic toxicity if you will perform your regional technique or regional block even under ultrasound guidance in a patient who is under general anesthetic. Do you believe it increases the risk of toxicity or not?
So I've heard the question that if you're using ultrasound guidance to give anesthesia, will it decrease the incidence or not? Certainly it will decrease the incidence because the ultrasound guidance will guide you to the nerve sheath, and then you can inject incrementally into the sheath, and you know exactly how much you're giving your patient. And besides, when the patient is under general anesthesia, you have full monitoring of your patient. Not like when you give blocks and the patient has, sometimes when we used to practice, we only put pulse oximeter or ECG for the patient. So when the patient is under general anesthesia, you have full monitoring of the patient and you have your full equipment around you. And with ultrasound guidance, of course, you will be able to monitor exactly how much volume you're giving. So this will decrease the incidence of local anesthesia toxicity by much.
Okay, I'm not sure if you can hear me now.
Can you hear me?
You can hear me now or not? So we have to record the next question as well. So
I
this is
answered the
another
question. I'm not sure if everyone heard me because I can't
somebody
hear
is
anything
asking,
from
can
my
I
side.
use lipid part of TBN when intralipid are not available?
Question as well. So this is another recorded question. Somebody is asking, can I use lipid part of TBN when intralipid are not available?
The question is, can the lipid part of TPN when the intralipid is not available? According to the AAGBI, the Association of Anesthetists of Great Britain and Ireland, and the ASRO, the American Society of Regional Anesthesia, no. It has to be the lipid infusion that is 20%. If you have 20% in the TPN and it's ready and it is approved by both of these, you can use it. Otherwise, no, you will be taking jeopardy. But anyway, come to think of it from the other side. We need lipid to emulsify, to cause the lipid sink to emulsify the local anesthesia molecules and take them down in the lipid sink. So you can use it, but it will not give the exact effects of the lipid 20% that is mainly manufactured for fighting local anesthesia systemic toxicity. So it has two ways in, and you can wait in, and hopefully none of us faces a local anesthesia systemic toxicity case. I hope this answers your question.
Thank you. So another question here is asking, can local anesthetic toxicity cause prolonged confusion in a male patient, 75 years, who received 25 mL of lidocaine 2%, which seems to be
So another question here is asking, can local anesthetic toxicity cause prolonged confusion in a male patient, 75 years, who received 25 mL of lidocaine 2%, which seems to be
lidocaine 2%.
Well, it depends on the situation of the patient. Sometimes it can be the cause of prolonged disorientation, and sometimes it can be an acute, minute embolus that happens in the brain. It depends on your preoperative assessment of the patient and your intraoperative assessment of the patient, and then your postoperative assessment for the patient. Local anesthesia should not be taken lightly by any anesthesiologist because it can happen late. So it can happen after you leave your patient. Sometimes in some areas of the world, people give local, for example, brachial plexus block for arm injuries, and they put the tourniquet and then they deflate and they leave the patient after the tourniquet is deflated, suspecting that the patient is fine, and then systemic toxicity happens. So you should always have a monitoring on your patient, and you should have someone who is staying there and looking at your patient. If the patient is disoriented, you should ask for a CT. It might be the minute embolism, or it might be the local anesthesia systemic toxicity on low grade. So always be cautious. Any more questions, please?
So the last question here we are taking is how to differentiate between long-acting or local anesthetic toxicity and allergy of para-amino butyric acid.
So the last question here we are taking is how to differentiate between long-acting or local anesthetic toxicity and allergy of para-amino butyric acid.
To answer this question, you cannot differentiate between them. When an allergic reaction happens, you will treat the allergic reaction the way it is, because there is no way that we can differentiate if the allergy is to the local anesthesia molecule itself or to the preservative itself. So, but usually it's for the preservative because people have preservative allergies. It's used other ways, so they are exposed to the preservative in other chemicals they are using. Some of these preservatives can be even used as food preservatives. So you don't know. You cannot differentiate if it's for the local anesthesia molecule itself or for the preservative itself, unless you're doing a prick test for the patient for this. Any more questions?
Thank you very much, Dr. Enas. I am recording this as well. I'm not sure if you can hear me, and we are sorry for this technical issue. We would like to thank you for this great presentation. We would like to extend our also appreciation to all our faculty and the organizer of this course. I would also like to thank Dr. Saad to invite me for the modulation of this course, and we will hope to see you again in another lectures during this series. So thank you for everybody. Thank you for the speakers. Thank you for the audience, and thank you for the organizers, and hope to see you soon with another lecture. Thank you, everybody.